On the show tonight, we are trying to separate the facts from the myths. You've probably observed that in the last 1 week or so, there have been complaints about the society's understanding of this particular war that we're all in, fighting the coronavirus. There is a preponderance of ignorance out there about the COVID-19, but there are facts also, and I guess we need to do more of this to separate the facts from the fiction, especially about a disease that is as deadly as the coronavirus. And you've seen people at the beaches celebrating Easter. You speak to them, they don't believe this COVID-19 thing is real. It is real. Some say blacks cannot be affected. That's a myth. We're going to try and go through a few of that for you tonight. But let's start with the very latest on the cases we have. And this should tell you that this is very real. 336 cases so far. And by any stretch of the imagination, this is grossly understated. This is as a result of what we are testing and what we are finding out. The more you test, the more you find out. And so it's clear that where community transmissions happening, this figure is definitely more than what the official numbers say. If we don't test, you will know. So work with this. And we also know that they've done some 44,421 tests so far, right? It has happened over the last several weeks. Now, put this in context. The United Kingdom, the UK, says they are working towards a target by the end of April that they will be able to test 100,000 people a day. Now, just think about that for a minute and put that in the context of this. This is how many people we have tested in the last several weeks, not a day. The UK wants to test 100,000 by the end of April in a day. And so that gives you a perspective of how our testing is going within this country. Now, a few more things to bear in mind also tonight. There are 17 treated cases. They have been discharged. They were tested twice, and in those 2 cases, they tested negative. And that is a good sign, and so they've been discharged. There are 605 cases categorized as mild disease and on treatment, and so that's good. When it comes to the critical cases, though, that we have recorded in the last few days, and this is something that the Ghana Health Service is watching very closely. 2 categorized as moderate to severe cases, but this last one is, for me, the most important positive news. None in critical states currently. That is good news for us, because it's at this point that you have to call on the ventilators. We know we don't have ventilators. Nobody has enough around the world anyway. So it's good that this is where we are with this in Ghana. Now, 8 have died. That is a sad one. And so for those of you out there who believe this somehow is a hoax, and because we are in a pretty hot climate, then the virus doesn't survive in this climate, think again. We're going to try and look behind the science behind that particular perception as well, which we think is a myth. 8 people have died. This is in Ghana. The climate being hot and humid doesn't matter at all when it comes to this particular virus. Of the 336 confirmed cases, 268 of them were reported from the routine surveillance. We also know that 253 of these cases from enhanced surveillance activities. Now, 115 from travelers and mandatory quarantine. I'm sure you know that already, both Accra and in Tamale. We know that for certain now. I want to give you the regional breakdown. So wherever you are tonight, you know what is happening in your region. You see Ashanti region there with 53 cases. You see Eastern with 41. You see Central, which is a very latest addition to the growing number of regions getting this, just a single case. Greater Accra, of course, has the bigger number of infections with 509 there. And so if you're Greater Accra, you have to be absolutely cautious with the cases as you have it. Let's go to the Upper West region. There's 7. Upper East is 4. Northeast is 1. And then Northern region is 10. If you go to the Western region, it's 1. And then a Volta is 9. Another one of those that just came into the picture. And all these are being managed quite closely by the health authorities. Now, there are a few myths that we're going to try, and by the way, all that you see here is not exhaustive at all, but this one has come up very strongly. The 5G question, that those who believe 5G somehow is related to the COVID-19 pandemic. We'll look at the science behind that and try and look at whether that is even possible remotely, and what the WHO actually says about that as well. My experts joining me have a lot to say about this, so stay with me. This is a myth. A second myth that we'll look at: the virus was created in a Chinese lab. Again, has come up. In fact, the WHO has had to respond to this. We'll tell you what they say and what the experts also say, and where possibly the virus emanated from. We also will look at another myth, which is that the vaccine developed will first be tested in Africa. Some say that. We've seen reports in Europe that said asking for the testing to be done in Africa. Many have objected to that. We'll look at that also very closely. Blacks are immune. This is a very famous one, I guess, until recently, where we started dying. In Ghana, we've seen cases. In fact, if you go to the United States of America, as we have learned over the last few days, an inordinate number of black Africans, black Americans in America are dying compared to the white folks. Even in communities where they're in a minority, if you look at the percentage spread, blacks are dying far more from the COVID-19 than the whites are. And so this, I guess it's just overwhelming. The evidence suggests that this is not true, but there are people in Africa, in Ghana, who still believe that they are immune from this because they are blacks by the color of their skin. The virus cannot survive in the African climate. Some say this is one of those, they call it a myth, but can there be some truth to this? We'll try and probe this further on the show tonight. And so tonight we'll attempt to do this separation of the facts from the fiction, or call the myth, when my experts join me on the show. Stay with me. This is a learning process for all of us as we begin to grapple with this particular COVID-19 virus. Thanks for staying with us here on PM Express. My guest all joining me via Skype tonight is Dr. Titus Bayo. He is the Deputy General Secretary of the Ghana Medical Association. Also joining us tonight is Dr. Yao Bediako. He is the Research Fellow, the West Africa Center for Cell Biology and Infectious Pathogens. Also joining us is Dr. Bertha Sewa Ayi, who is specialist in clinical infections, diseases, and adjunct assistant professor of medicine at the Kansas Health Sciences Center. I'm grateful that a lot of you could join us. We're also joined by Dr. Michael Owusu. You know him, he's almost a regular on this show. He is a virologist in the Department of Medical Diagnostics at the KNUST Research and researcher at the KCCR. In fact, I want to start with him, Dr. Michael Owusu, on this. Thank you all for joining me via Skype.
Thank you.
Dr. Owusu, I want to start with you. I want to start with a story that emerged last week, Friday, from Wale Wale. A 19-year-old boy who died, and I dare say possibly our youngest fatality yet in Ghana from the COVID-19. 19-year-old died in Wale Wale. We learned later that he had asthma. Now, since you're talking about facts and myths, there's a myth that says that teenagers cannot be killed by the coronavirus. But however, we saw that case. How do you explain something like that? Because we've constantly been told that it is the elderly that is most at risk of getting critical and dying from this. But how do you explain a 19-year-old dying from the COVID-19?
Yeah, so
Initially, when this outbreak started, looking at the trend of the data, China, and then also from Italy, we thought that the virus seemed to cause more severe disease among elderly. But then the trend in the US started showing us a different picture. We saw that very young people, some with underlying conditions, some without underlying conditions, have died of this virus. One of the scientific interpretations for this, which is not published though, but some have come up to say that it is possible there could be 2 or more strains of the virus circulating. Some group of scientists believe that there is the Lita strain that could be more aggressive and could cause some more deaths among both old and people. Then there are other mild strains which could be asymptomatic carriers and those who have very mild disease and people could be better at recovering from this. I'm not too sure the strains that we have, which of these 4, but I think that we really recently had a sequence strain from colleagues from the West African cell biology research group. And this will give us some idea of where we are importing our strain. And perhaps it may be helpful if we can understand the strain that this young man had and for which reason he died. So while he had underlying conditions like asthma, you may think that perhaps the virus complicated the asthma condition in the boy. This could be why the reason why he died. But understanding the strain, the nature of the strain, and to see whether this strain is different from asymptomatic carriers and those who have mild disease, will help us know whether perhaps we could have some of these Lita strains which could form clusters of strains in the US. And that will help us to understand the epidemiology of the virus circulated in Ghana. So the myth about saying that it's solely for elderly people, I think that we should begin to review this and then understand this. Well, if you are young and you have underlying condition, the disease may be severe in you, but then it is possible to be young without any underlying condition, but then you may have a more aggressive strain that could complicate your life if you don't take very care of yourself. So I think things are evolving, and as data accumulates, better understand what the virus does to
I want to bring in Dr. Bediako now on this question about the strain, and then the question about age and the role it plays in infections when it comes to COVID-19. Dr. Bediako, what do we know? I mean, part of the reason we are having this is also for public education. And so those out there who believe a certain myth at least can get educated on and disabuse or debunk those myths. I just heard Dr. Wusu say, yes, age can play a role in the level of risk that one gets and exposure and possibility of death. But he also mentions the question about a strain of the virus that can also be a factor. What do you say to all that and the fact that a 19-year-old died? That's a teenager there. I mean, isn't that an outlier?
So thank you for having me on. I think, you know, with COVID, we are learning a lot each day. I mean, that's why it's called nCoV. So it's a novel coronavirus, a virus that we've never seen before. Yes, it is true that in general, if you look at most of the deaths that have happened globally, they do occur in individuals who are older. And so that would suggest that people who are beyond 60 are more at risk of dying. But it doesn't mean, when they say you are more at risk, of course, it doesn't mean that younger people are completely protected from death. They are less likely to die. There are cases where younger people do die. So I think we have to be clear that no one has said, none of the data suggests that young people are immune from severe disease. It's just that if you look at the general distribution of cases, you find that in general, older people appear to be more at risk. But there are indications that young people, whether it's underlying conditions or in some cases just their own genetics, may in fact succumb to the disease. Now, in terms of the strain of the virus, we are still, as I said, learning a lot about the virus. The previous speaker mentioned the 15 genomes that our center, in collaboration with Noguchi, were able to sequence recently. And from that analysis, we found that the viruses that we found in Ghana, the 15, fell into 3 clades, which are sort of groups. When you do phylogenetics, when you study a virus, you can sort of group them according to their genetic structure. And actually, when we tried to align the clades or the viruses we found in Ghana with viruses detected in other parts of the world, you actually find that the viruses detected in Ghana sort of aligned with many different clades. So they aligned with viruses that had been sequenced from the UK. We had some that were similar to ones in the US. So it did not appear as if there is a huge difference between the Ghanaian circulating virus and the viruses that have so far been isolated in other parts of the world. Of course, this outbreak is relatively new, and in Ghana, compared to China and even Europe and North America, we are sort of a little bit later in the progression. So it's relatively more recent here. So the reason why sequencing will continue is to see whether or not in time the Ghanaian strains will evolve away from the strains we see in Europe. Currently, the strains we found in Ghana are quite similar to the ones found in China and found in Europe and North America. Actually, they are about over 90% similar to the original Wuhan strain. So it's early to be able to tell whether or not there is a more pathogenic strain versus a less pathogenic strain. I think we need a bit more time and a bit more research to really be able to definitively say that there are different strains that are linked to different pathology.
Fascinating. I want to bring in Dr. Bertha Serwaa-Aye. And Doc, thank you for joining us also. I'm happy that you're joining us from the United States, because if any country had done a lot more research in this and understanding the trends when it comes to age and the role it plays, I think the US had done that quite rigorously, because a few weeks back we started learning from the research that the CDC and others are doing that the US is recording pretty young deaths, and the range of deaths was spreading across, and infections really was spreading across very young ages. Chip in for me, if you may, Dr. Serwaa-Aye, from what the US is learning when it comes to age and how it may predispose you to COVID-19 and possibly the possibility of fatality there.
So I don't think age particularly predisposes someone per se, but I think it's more the manifestation of the illness. And so probably the best example I can give is a family in China where the parents presented very ill, and they had a 10-year-old who was literally playing. I think the hospital decided to test the child. Not only did he have a very high viral load, but when they did the CAT scan of the chest, he actually had pneumonia, and yet he was playing while his parents were sick. So I think it's more of the expression of the illness. For some reason, in Asia, only 2% of disease was found in people below the age of 19. But once it got to Europe and America, the picture was completely different. Because in Spain, you had a 21-year-old soccer player who died. And United States have reported deaths in 16-month-olds and 16-upper-olds babies. So I think it's the expression of the illness that is different.
Okay, very good point. I want to bring in Titus Berrio, and then Titus, take this for me, because we saw the beach pictures over on Monday or the Sunday. People went to the beach in their numbers. A lot of them were young people, and I'm going to be addressing this. Some young people think that, oh, I mean, I can still socialize, I can have a party. In fact, the police have arrested a number of young people who were throwing a beach party and a pool party in the last few days, because they somehow believe that, well, look, I mean, even if I get it, I'll survive, I'm young. Is that a myth?
Indeed, it is, and I will want to state it emphatically that as the previous speakers have spoken, age alone is not protective. And in Ghana here, a lot of us do not know our health status. A lot of these young guys have never been to any hospital and do not even know if they have any underlying condition. And so to live in that false belief that just because we are young, when we get this, we survive, is very erratic. We need to debunk that myth and state the fact it is that the young can die, the elderly can die. I think the most predictive factor for mortality is underlying conditions. And in a country where people, you have no clue what you are walking around, and again, you don't know how the disease will manifest in you. So don't live with the expectation that even if I get it, I'll survive. I think that is very sad.
Yeah, I mean, I want to, let's move on to the next minute. And so the takeaway for me then, if you're watching this at home and you're young and you think that you could have fun, all these experts have told you that don't joke with COVID-19 because you are young. We've seen a 19-year-old and they've explained it, that it's pretty much no respect of age. And you may be walking around with some underlying health condition you don't know about, and you might find out very late that you went to a party when they say lockdown and stay at home and get infected, and then realize too late that you had an underlying health condition that, you know, led you to die. Nobody wants that to happen. And so dismiss that. It's a complete myth that if you're young, it can kill you. Let's move on to the next myth. And Dr. Bertha Sewai, I want to bring you in on this myth. It's a big one, which is that blacks are somehow immune. I'll come to a related conversation to that. In the US, you are actually realizing from the data that blacks are actually more susceptible to infect and die than the whites. Explain that for me.
Okay, so I spent the good part of January and February trying to convince people that the fact that one Cameroonian recovered in China does not mean that black people are immune. I mean, you cannot make a generalization for a whole race just based on one recovered patient. I was trying to tell people that the fact that he got infected shows that blacks are equally susceptible. So fast forward, now in most cities where black people make up maybe 23% of the population, they're finding that those affected are blacks to whites, maybe 50 to 50. And then up to 83% of the deaths are in people of color. So it is a very simple explanation. People who have diabetes, high blood pressure, asthma, obesity, and heart disease have a higher chance of progression to death. Actually, for diabetes, the risk is 30%. And for diabetes, it's easy to understand because if you do a blood smear and look at the blood of somebody with diabetes, in the presence of an infection, their white cells move very, very slow to attack any virus or any pathogen. So we've always known that diabetics are more predisposed to infections, which is why they get foot infections and all that. So their response to COVID-19 is no different. So specifically in relation to African Americans or black people, it's always been known that we have a higher rate of diabetes mellitus and higher rates of heart disease and hypertension. For hypertension, it's pretty much genetic, and Professor Adi studied this in Ghana for years, that black people have more high blood pressure. But when it comes to diabetes and obesity, there is a secondary layer that is produced people of African American descent in the US because their social conditions influenced by other factors like access to physicians, access to education, access to good housing, and a whole lot of social determinants of health. Because if you don't know, you're not educated enough checking your blood sugar, you're going to have uncontrolled diabetes. If you don't go and see a physician, you don't know to change your diabetic medication. So it's actually two layers of problem creating the ripple effect that we see. all these social determinants, coupled with the fact that because of the social determinants, if all these other health problems, and so when COVID-19 hits, they are more predisposed. And generally, Black people also love being together. Like with all the social distancing, they would still want to go and see a cousin or pass by and say hello to someone. And so it's all these other factors together that make it look like they have more, or not. Like the actual thing is that they have majority of them are more predisposed to die. But in terms of susceptibility, they are equally as susceptible their Caucasian counterparts.
Dr. Bediako, let me bring you in here and explain this for me, and I've been trying to process it. We are at least 5 months into the pandemic. I mean, it started, I think, in December. We are in April, right? If you compare Africa's exposure, death rate, and everything else to what Europe and America is suffering, I mean, Africa seems to be doing great. Number of deaths very low. Number of infections still pretty very low. Isn't it a case of our genetics as Black people in Africa that is making it so easy to win this war and not have the thousands and thousands of deaths and infections we are hearing of in Europe and in America?
No, I think we have to be careful. The pandemic is not 5 months old in Africa. It started in China and it moved gradually across the globe. And in actual fact, in Ghana, for instance, the first reported case was in early March.
Sorry, I was talking about the global scale, the global timeline, the global timeline.
Yes, but even in Africa. So my point is, in Africa in general, the cases were reported a bit later on than, for instance, well, certainly in Asia, and when you compare in Europe. And I think that's partly to do with the movement of people. There are many flights across from China straight to the US or to Europe, and it took a little bit longer for the virus to make itself visible in Africa. So we are, if you look at our timeline, we are not the same place that, for instance, Italy is. Okay. The virus has been in Italy longer, at least detectably longer. Now, I will also say Africa, as you mentioned in the beginning of the show, we don't test as much as other parts. There are certain countries in Africa that are not testing at all. I think Burundi only recently reported its first case. Ghana is probably one of the best in Africa for testing. So people may be dying. They are just not, their deaths are not attributed to COVID. And so it would look like COVID is not killing people. So we have to be careful with that. But I think another thing is, genuinely, the virus has gotten here a bit later, and we are a few weeks, if not a month or so, away from seeing whether or not it will have the same effect. We do have a younger population. The average age in Africa is 19. Yes, as Dr. Titus mentioned, we don't know our underlying conditions, so just because we are younger doesn't mean we are necessarily more protected. However, we do have a younger population, and so there is a chance that we could see a little bit less death. But I think we have to be very, very cautious. This is an evolving situation. Ghana today has reported over 600 cases, and that number is sure to rise. So if you look at the percentage of death, if you look at the number of cases, and we have 8 deaths, that percentage is not that different from a country that has 500,000 cases and has 20,000, like the US does. So we have to be careful. As our case numbers rise, it is likely that our death numbers will rise. So we have to look in terms of proportions, not absolute numbers. And then also remember that temporarily, we are sort of a few weeks at least behind the Italies and the Spains. So let's give ourselves a few weeks and see where we stand before we get any conclusions about whether the virus has skipped us or has been less severe in our part of the world.
Dr. Wankalusi, let me bring you in. So I look at the figures, and we were told today that we've tested in the region of 44,421. Out of that, we have only, and this is a myth-busting show, and so I'm going to people are going to think like I'm thinking. So I'm putting it to you. We have 44,421 tests, positive. Test. Positive is 636. Death is only 8. The percentage is negligible. if you throw that across the continent, you're seeing similar reports of it really not. And here's the kicker: if you see the impact, even if you are not testing, you will start seeing impact on health infrastructure, right? Because even if you are not testing, people will still get sick and go to the hospital. Today we're reporting that in terms of critical patients due to COVID-19, only one, in fact we have none on a ventilator in a critical condition. Again, back to the question about meds. Is it the genes and the black man that is doing this? And then linked to that for me, the climate question. Is it because we are in a hot, humid environment that is making it hard for the virus to spread? Please deal with that for me, Michael Usu.
Yeah, so I think we have to be very careful. It's too early, actually, too early for us to begin to think that the virus is not going to cost a lot of lives like as it was. So the mortality rate, or the case fatality rate across different parts of the country, it's some 4-5%, others up to 7%. And then, I mean, in Africa, we have 15,738 cases, 838 deaths in the whole of Africa. Burkina Faso has currently 28 out of 515. If we strike the percentage, it's around 5%. So it's only a matter of fact. And you need to weigh the number of people who are being infected against the rate of hospitalization. And then you also have to compare this to the number of ICU beds in terms of bed utilization in our hospital. So most of the cases we have seen that are asymptomatic rates, people who came through mandatory quarantine, and people who have been there since the 3rd month and who are still having the virus. The majority of the cases came from this mixed group. We have not started recording the hospital cases yet. So, and this is what makes the difference. When we begin to have spike cases and many people have been infected, many are trooping to hospitals, and then you have health personnel being infected and some being quarantined. So we begin to deplete the health sector. Then with your limited bed capacity, the low human resource, many people need to treat them. Then you can properly weigh the effect of this. So I think that indeed the virus, there was some time for the virus to get to African. But I think that it's not exactly following exponential curve like elsewhere. Other variables could play, but we can't tell now unless we begin to look at other data.
Dr. Usu, because you're a virologist, forgive me, because you're a virologist, let me ask you this. Does the climate play a role in this? Does our climate play a role in the ability of the virus to first survive and the spread?
We've known coronaviruses for years, and weather does not play a significant role in terms of infectivity of the virus. Human coronaviruses, we have 9 to 10% of Ghanaians who are infected by the normal 4 types of human coronavirus. This was 2014. These are local communities that we detected this, and the weather is hot there. Yet they had about 10% of them having this. We know in children less than 5 years, you have 5 to 10% of them having pneumonia as a result of the human coronavirus. So, and this new coronavirus is a sister strain of this human coronavirus. So I don't expect it to behave different in our climate. But what I think, which is not based on data though, is that the climate may slow the spread of the virus. This is why I think in Africa, we are progressing at a very slow pace, but eventually we'll hit a peak. But if it will take you 2 weeks to get to the peak, it is possible it will take you about a month or 6 weeks or 2 months for you to hit the peak. This is why we must be more aggressive. And this for me is a window period now. We have the luxury to put in all the systems that we have to put in. We need to put in all the infrastructure. We need to use all the mobile technologies and everything that we need to do now. This is the time for us. Else, if we don't activate the systems and just keep on to this next, I think that we're going to surprise ourselves.
Okay, great. Let me bring in Titus. Titus, you are at the receiving end of this. What's your reaction to that question, that myth, that, yeah, I mean, listen, yeah, we are not as badly hit because, one, we are black and because of our climate. What do you say to that?
So just as the earlier speakers have said, I think we should treat it as a myth that must be busted immediately, and that this is not the truth. Rather, if you follow the history of disease, you realize that it's really based on movement of people. And like I think Dr. Bedia said, it took much longer time for people to move with the disease into Africa. If you take Ghana in particular, I think we've done a few things right, even though some of the things were a bit late. The fact that we are getting the people in quarantine and then we are diagnosing the people when they are not really sick in itself is a very good thing for us. And I think maybe luck is also shining on us because our health systems cannot support when we get to that terrible state. If you look at a lot of countries, if you take the Europe, if you take the Americas, what we here have analyzed, and it looks like, and I think Beta may speak better to this, is that the youthful people travel to these other countries and bring the disease. And they come and infect the elderly, other people, and then the death starts to rise. If you take Ghana, we are in that phase where most of the people with the disease are those who have returned and those who've had contact with them. These will be youthful people, very strong people walking around. The next phase is that these people are going to carry this disease throughout the community, to infect their parents, their grandparents, to infect more elderly people who will be more prone. And that is when we are going to begin to see the terrible picture of more numbers die. So if we are able to contain it now, before that spread level gets to the more vulnerable population, I think the better it will be for our country. So let no one kid ourselves that our environment protects us, our genes protect us, the humidity protects us. No. It's being found in Burkina Faso. Burkina Faso is, relatively, maybe even warmer than us down here. In Ghana here, preferably the north is warmer than the south, normally. But we found it in the north, we found it in the south. So it tells you that really, even though the humidity may play a role, temperature may play a role, these are not really founded as of now. We should just brace ourselves up and contain this early.
Yeah, I mean, Doctor, you find out, give me a quick thought on this. I'll go for a break and come back. I think we may have lost your sound there. Okay, I can hear you. Go on. I can hear you. Great.
Yeah, I said the virus will die at 56 degrees Celsius, which means if you boil your food or something, it would die. But if you think about it, there's nowhere in the world 56 degrees Celsius, about 130 degrees Fahrenheit, and unless it's in the middle of the volcano, I don't know any part of the world that gets to 130 degrees. Not even in Texas, not even in the desert. And so I think that the temperature issue is not a big one. And you also just have to look around the equator of the world, and you find that other countries that are on the same equator level as we are have had lots of disease, lots of cases. So we just cannot use that. If you think about the fact that the virus can survive for up to 40 days in an air-conditioned room at 70 degrees Fahrenheit, then it tells you that it's non-issue. And then look at our own body temperature. Our temperature is about 96.6 degrees Fahrenheit, or if you take Celsius, about 36.7. The virus is able to survive in us. So the fact that we're thinking at 80 degrees outside the body, it won't be able to survive, it's quite a big, it's quite a myth. And so I don't think that's at all.
Great. Gentlemen and lady, please stay with me. Great education so far. and I'm learning a lot. If you're one of those who are thinking the way people have been thinking, now you've heard from the experts. When we return, we're going to look at other myths peculiar to this part of the world. There are those who believe, well, the virus, if I drink a certain concoction, say, I mean, several things have been said. I mean, you know, there's a chloroquine bit. I'm going to come to the chloroquine bit, and I will survive this. And people are saying if I drink alcohol, some have mentioned, well, it won't kill me. Well, I'm going to return and I'm going to get the experts to weigh in on these myths as well. Stay with us. You're so live on PM Express tonight. A great education, tackling some of the myths that we've heard people bandy about when it comes to the coronavirus. You've heard a lot of those myths busted tonight on the show from the experts. We have Dr. Titus Bayo, who's the Deputy General Secretary of the Ghana Medical Association. Also, as Dr. Yao Bediako, who is a research fellow with the West Africa Center for Cell Biology and Infectious Pathogens. Also with us is Dr. Bertha Sewa Ayi, who is a specialist in clinical infectious diseases and an adjunct assistant professor of medicine, Kansas Health Sciences Center. And of course, Dr. Michael Owusu is a virologist and a Department of Medical Diagnostics, KNUST, and a researcher at KCCR. Dr. Owusu, another myth that has gained global attention recently, and I've seen the WHO been forced into issuing a statement about this, is that 5G network somehow is causing the virus spread. Is it possible that 5G can cause viruses and this particular COVID-19, from what you know about viruses?
No, I was a bit surprised to hear that, and I don't know why. I'm trying to understand why this thought, but I still don't understand. Viruses are small, ultra microscopic organisms. So they are with us. I mean, the organism needs to move, you need to attach to a surface of the body. You need to interact with the cells of the body. You need to enter into a cell and undergo a replication cycle, and then trigger a whole process. So I don't see the role of 5G. It doesn't travel to radio waves. Mm-hmm. It doesn't work like so. It is a bit. I just can't understand why people feel that 5G. Something that 5G has an effect on the immune system, but this is false. We don't have any data to support this. That 5G has something to do. So it's a myth that I think we should just not even worry our head to.
Okay, great. Thank you very much for saying that. I want to quickly read you what the WHO says about this. It says viruses cannot travel on radio waves, mobile networks. COVID-19 is spreading in many countries that do not have 5G mobile networks. COVID-19 is spread through respiratory droplets. When an infected person coughs, sneezes, or speaks, people can also be infected by touching and a contaminated surface, and then their eyes, mouth, or nose. And so WHO, and as you just said, Dr. Owusu, say quite clearly that is a myth. Disregard it. Dr. Bedi, I'm going to come to you with another one. This is an interesting one. If you're a Ghanaian, and so you should understand this. There are a lot of people who say putting the neem tree in hot water and covering yourself with a thick blanket, somehow the vapor from that can evaporate the virus from your system. Is that true?
No, I don't know how else to answer it. It's not true. I think this arises out of the idea. Neem obviously is thought to be anti-malarial, and I think all the noise made in the US and other places about hydroxychloroquine, which I think you're going to come to, has raised this association between coronavirus and malaria. And so people are thinking that things that they think might help with malaria, even malaria, if you sleep under a blanket, believe you me, I study malaria, and if all you do is sleep under a blanket, we won't make it either.
Okay.
So I think this is just sort of an old wives' tale. Conflating malaria and the potential benefits of neem itself, perhaps as an anti-malaria, but certainly usually that is as a herbal remedy, and even that certainly has to be taken as a drug, and I think even against malaria has some effect, but it's not entirely, it's not what I would recommend to treat malaria as a first line. And certainly against coronavirus, even hydroxychloroquine is not proven. There have been conflicting studies. One study, small study, showed perhaps some benefit. Another study showed no benefit. And I think the biggest concern about hydroxychloroquine, if I would, jump into that, is that it has severe side effects. So it's not recommended as a prophylactic. And there are patients who have lupus, who have rheumatoid arthritis, who depend on hydroxychloroquine. And so the global rush to buy chloroquine has actually put people at risk. So now there are shortages of chloroquine that is causing problems. People should, the main thing, no, it's not going to help you. And chloroquine is likely not going to help you until we have evidence.
Okay, Dr. Titus Bayo, you on the front line. Are doctors treating COVID-19 cases in Ghana prescribing chloroquine?
Yes, it is part of our current treatment protocol. Has been suggested elsewhere, there is data to back it, but the data is not very conclusive. And I know that trials are on the way, but currently our national treatment protocol in draft, which we are using for managing the COVID, includes hydroxychloroquine. However, mindful of its side effects, which could be potentially lethal or deadly, like arrhythmias, our recommendation is that this must be done in a hospital setting and not for prophylaxis. So we recommend strongly that no one should take it on their own. It has to be prescribed for you by a doctor, and you should take it in hospital. Because, like I mentioned, hydroxychloroquine has a side effect. It causes the heart to beat irregularly. That is what arrhythmias means. So it can essentially cause your heart to block, to stop beating, and it can be dead. And therefore, taking it on your own, it's not advisable. People may say, oh, we have used a good old chloroquine for malaria, we know it, yes. But under these circumstances, its neighbor, which is hydroxychloroquine, azithromycin, which are part of our draft protocol that we are using in the treatment centers, we are only using them in hospital. So no one should use them for prophylaxis. But to give it a fact, yes, we do use it in some of the treatment centers.
I mean, Dr. Ayi, quickly also on this, because I know in the U.S. right now there's a debate around this. Donald Trump, he was talking about this. The FDA says, listen, we haven't tried this. What's your own take on this? Is the U.S. using it? We are using it. Is the U.S. using it already? And what is the impact of this?
Several hospitals in the United States, including mine, are using chloroquine. I've had to dig up my pharmacology book and read all about chloroquine over again. And I found it interesting to note that you could literally kill somebody by giving them a total of 5 grams of chloroquine at once. So I agree with the first speaker. It's not to be taken lightly. The doses that we used for malaria was a very small dose, and we used it under very controlled conditions. I've had patients on chloroquine who had elevated liver enzymes. It's not supposed to be used for people with liver disease. There's a lot of hepatitis C in Ghana. So people with chronic liver disease have help using it. People with seizures or who are taking anti-epileptic medication should be very careful. But let's even look at the study that was done that supported chloroquine. So this was done in France, and it was a small population of people. And what they were measuring was nasopharyngeal clearance, which is the test we do to say somebody is positive. We're essentially swabbing the virus on its way into the lung. And so I don't know why we call it a cure. And the reason why I'm saying that it may not be the best test is the fact that coronavirus can cause brain infection. And people have died, and autopsies have been done. And they found that the virus is alive and awake in brain tissue, liver, stomach, and all these organs. So you kind of, when you know all this information, you sit back and ask yourself, so what was the value of a nasopharyngeal swab? Because really the person has a pneumonia. And so if you're using a swab to determine whether chloroquine has been effective, maybe a better study would be to maybe take tissues. And I'm saying the test is not the all in all, because I have a patient right now that we have to test him 4 times. It was just this week that finally the blood test was positive. And I felt glad that we kept him in isolation, because the decision kept on coming back. Dr. Ayi, should we take the person out of isolation? I said, you know what? The cost of making a mistake is a huge PPE. If this patient is really positive and we take him out of isolation, he's going to expose a whole lot of people. So yes, we're using chloroquine, but the other thing that have been useful into this new drug called susceptibility, it doesn't actually kill the virus, but what it does, it suddenly reduces the inflammation storm or inflammatory storm that is associated with leukemia.
Okay.
And both chloroquine and this drug have been used for rheumatoid arthritis for years. So it looks like the rheumatoid arthritis drugs are coming to our help.
I'm grateful. I'm grateful that we both all of you address this, and so that the point, I guess, to take away for me is don't use it at home, because it can kill you. We'll be hearing it. I mean, I think for me it's a fundamental. Don't use it at home. It can kill you. And very quickly, in 10 seconds, Dr. Bediako, alcohol. Does it do it? If you drink a lot of akpeteshie, does it kill the virus?
Akpeteshie on your hands, it might act as a hand sanitizer. But if you drink it, you're just going to get drunk and probably end up with corona anyway. Okay, great. And Dr. Wusu, 1 second if you have, and then this is a question. It was a question about whether coronavirus and well, I just ran out of time on this particular one. But I'm grateful, gentlemen. I've learned a lot. Very exciting to have you busting the myths for me. Dr. Bediako, Titus Bayo, Dr. Bertha Ayi, and Dr. Michael Wusu. Thank you. I'll probably have you back to explore more myths as they emerge. Thank you very much. Thank you all for joining us on PMS. I hope you've learned a thing or two. I have. Enjoy the rest of your evening.